Yeah, thank you. I hope I'm audible.
Yes,
So,
you are.
yeah, this was a good analysis which got presented even at ASCO about 1 to 49% what to use, IO or chemo plus IO. As was talked about in the background, we know that greater than 50% IO over chemo IO is an option in NCCN. PDL1 1 to 49 again has this both these options, but this analysis focused specifically on this subgroup of patients to try to understand if we are looking at these population of PDL1 with 1 to 49, they don't have any EGFR mutation, any driver mutation. Is there any difference in OS, a difference in PFS, and whether this difference in OS and PFS is by any subgroup, like whether elderly benefited only with IO and didn't benefit with chemo or IO. So they also looked at age, performance, and smoking history. What they did nicely was they took data was pooled from all RCTs for which an FDA approval was given and which had this arms of chemo, IO, or IO itself. PDL1 expression was kept for as for TPS and no CPS was entered in. And they looked at two outcomes, OS and PFS. They were looking at adjusting these outcomes with respect to age, gender, race, performance status, histology, and smoking. And these were the subgroups they were actually focusing on. Age less than 65, 65 to 74, greater than 75, performance status 0 or greater than or equal to 1, and never smoker or ever smoked. And these were the studies which were included in this. The Keynote 042 with pembrolizumab, the NEO-EP, other three pembrolizumab studies, the atezolizumab studies, and NEO-EP study itself also was included. The total population which they got was 6,010 patients. When they looked at only those with EGFR or ALK wild type, it came down to be 5,800 plus. When they went for PDL1 evaluable, it came down to be 5,700 plus patients. And when they restricted the analysis, which was what they wanted to look at, 1 to 49%, it came down to 2,000 patients. And when they restricted it to chemo, IO, or IO, not only chemotherapy was excluded, it got restricted to around 1,100 samples. And this was the distribution which was seen in this group. You could see that there were most of the patients were, I would say non-elderly, 50%, but there was a 50% chunk was greater than 65 with around 10% above 75. Most of them were white. Most of them were smokers. ECOG greater than 1 occupied 65% of the overall population, and non-adeno was the predominant one. Now, this was interesting. When they looked at the median overall survival, what they noticed was there was a statistically significant improvement in median overall survival when you had a combination of chemo plus IO over IO alone. So this was also seen with respect to the progression-free survival curves, where chemo plus IO had a betterment over IO alone. What does this suggest? This suggests that in these patients, if you give chemo plus IO, there's an improvement in PFS and an improvement in OS. So let's try to dissect according to the important pre-specified groups, which were the patients which benefit most from this. And when we look at this, we see that fit patients, that are the elderly patients, non-elderly did benefited. 65 to 74 also benefited, but patients who were greater than 75 did not benefit. Patients who had a ECOG performance status up till 1, the benefit was also there. And irrespective of the current or never smoker, they benefited. What it suggested that if your performance status, if you're elderly and performance status is not that good, then the benefit with chemo plus IO is not as substantial as with in the non-elderly and good performance status. So though this would be termed still as a retrospective exploratory analysis, because this data was prospectively collected for some other investigations, and out of those studies which got included, only 2 trials were with IO alone, and the rest data got extrapolated. And this is a clinical trial population, so even the elderly which was taken in this population between 65 to 74, which you see here, it would very well have been a supra-selected elderly, which may not have any comorbidities and which would be very fit. So direct utilization of this data in the real world may be difficult. And an important aspect was that the PDL1 status assessment across all the trials was different. Leaving that also, this data came from prospective randomized studies. It gives you an idea of what to do in clinical practice. I think what it tells us is if you have a non-elderly patient and then the patient is a fit patient with its performance and comorbidities, giving a chemo plus IO is a better option than IO alone. And that would be also my take on this topic. That's it. Thank you.